On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Antibiotic Stewardship Webinar Series, Antimicrobial Usage. My name is Amanda Bennett, and I will be your moderator for this program. We welcome any comments or questions. All materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar. Christine Bingman is an infection preventionist for the Patient Safety Authority. In this role, she is responsible for education and outreach for infection preventionists in all levels of healthcare. Christine has clinical infection prevention experience as an infection preventionist and a manager of infection prevention for a large health system, as well as a director of infection prevention in acute care, behavioral health, long-term care, hospital-based clinics, ambulatory surgical sites, and long-term acute care facilities. Her clinical experiences enable her to assist others in setting priorities for patient safety and to serve as a content expert in developing infection prevention strategies and solutions for our healthcare partners. Christine, I will now turn the program over to you.
Thank you so much, Amanda, and thank you to all of those who have joined us this afternoon for our Antibiotic Stewardship Webinar Series. Today's focus is on antimicrobial usage, and the intent of this webinar series is to assist you in forming an antibiotic stewardship program. And so we'll move forward to our objectives for today's program. So at the end of this webinar today, we're hoping that you can describe indications for using prophylactic antibiotics, define empiric antibiotic therapy, define pathogen-directed therapy against a specific microbe with known susceptibilities, and then describe strategies to improve antibiotic usage within your organization. So the why. Antibiotic usage has been tied to negative outcomes. Approximately annually, the prevalence of antibiotic usage in long-term care ranges from 47 to 79%. More than half of the antibiotics that are prescribed are not at all indicated. And inappropriate prescribing with the wrong drug, the wrong dose, or a lengthy duration, it has adverse effects which can cause such diseases as Clostridium difficile, we use the old term, infection. It also can cause adverse drug effects, drug-drug interactions, and antimicrobial resistance. So we really want to ensure that our residents are prescribed the right antibiotic for the right length of time and for true infections. So we'll just recap some terminology from the last couple of webinar presentations. Antibiotic stewardship is an activity that promotes and optimizes the appropriate use of antibiotics for the right person and the right length of time to prevent adverse events. Often, a physician will prescribe empiric antibiotics, and these are a method of antimicrobial therapy that is described for a likely cause of an infectious disease. Prophylaxis, these are antibiotics used to prevent disease before the presentation of symptoms, whereas pathogen-directed therapy is targeted antimicrobial usage based on susceptibilities or resistance to antibiotics. Broad-spectrum antibacterial drugs that inhibit a variety of gram-positive and gram-negative organisms. So the drug itself is able to kill a variety of organisms, both gram-negative and gram-positive. Narrow-spectrum antibiotics are those antibiotics that are only active against a limited variety of organisms. So not something that we would want to prescribe unless we were sure that the resident had a specific organism. Susceptibilities is a testing process used to determine the effectiveness of specific antibiotics. Bacteria are susceptible when it's unable to grow in the presence of one or more antimicrobials. a resistant organism is able to grow uninhibited in the presence of antimicrobials. So these are, if you think about methicillin-resistant Staph aureus or vancomycin-resistant Enterococcus, these are organisms that are able to grow in the presence of those antimicrobials very well. Intermediate susceptibilities are those bacteria that are able to grow uninhibited unless the antimicrobial concentration is higher or the frequency of the drug administration is increased. And then finally, minimum inhibitory concentration. This is where we get into the micro of antibiotic stewardship. This is the lowest concentration of an antimicrobial that will be effective to inhibit growth. So I'm going to touch just a wee bit on minimum inhibitory concentration. This will be covered in more depth in a later webinar, but I felt that this was appropriate to cover right now since we need to have the knowledge in order to move forward. So there are two methods to identify sensitivities. One is the determination of the minimum inhibitory concentration by adding a residence organism to tubes containing decreasing amounts of antibiotic. The incubation period is controlled by temperature and time, and the lowest concentration of the antimicrobial is known as the minimum inhibitory concentration. Another method is the disc diffusion and the zone of inhibition. So depending on the diameter of the zone determines the sensitivity to the drug. So resistant organisms are going to be able to grow all the way up to the disc itself. So if you look at this particular slide, the organisms or the discs on the right-hand side have large zones of inhibition, whereas the discs on the left-hand side have no zones of inhibition, and this would be considered a resistant organism. So this is an example of a susceptibility report. This is for a tracheal aspirate, and the organism is Pseudomonas aeruginosa. On the left-hand side, you have your common antibiotics. In the middle, you have your minimal inhibitory concentration. And then on the right-hand side, you have the interpretation. So the minimum inhibitory concentration is, again, the lowest concentration of an antimicrobial that will be effective to inhibit bacterial growth. The numeric value is in micrograms per ml of an antibiotic that inhibits the growth of a strain of bacteria. Next to the minimum inhibitory concentration is the susceptibility interpretation, which is either sensitive, intermediate, or resistant. Sensitive implies that the organism is inhibited by the serum concentration of the drug. Intermediate implies the organisms are inhibited by the maximum recommended dosage, and resistance means the organisms are resistant to the usual achievable concentration of drug levels. So the next slide here is pathogen-directed therapy, and we want to use this process to determine the best way of treating these individuals that have grown a bacteria in a fluid. So the culture with antimicrobial susceptibility results, we're going to use that to determine what is the best method to treat that particular organism, what's the best antibiotic. And then in addition, maybe we want to consider first identifying a specific microbe through polymerase chain reactions, looking at nucleic acids of a bacteria. Maybe we want to consider serology as a means to determine what infection process the resident has going on. And then probably a great way to really identify what needs to be done for a resident is through culture and non-culture diagnostic testing. So one of the recommendations for us as infection preventionists is to perform surveillance. So we typically use McGeer criteria, and we are to apply that criteria, and usually it is retrospectively with diagnostic testing results. Then there is the need to identify events to estimate actual incidence and prevalence rates. So how often is a UTI occurring within our institution or a bloodstream infection? Infections in long-term care do not always meet the surveillance criteria because residents do not have typical symptoms. That's why we use the McGeer criteria. This is based on presentations of symptoms in older adults who are unable to mount a typical immune response. We need to identify true case events, and our surveillance criteria are not intended at all to be used for clinical decision making. These are only to identify events for reporting purposes. Surveillance criteria were developed to remove subjectivity and produce comparable surveillance data across a population. The clinical criteria are used to treat residents and not surveillance definitions. Clinical criteria allow for informed decision-making and identification of the best treatment possible prior to diagnostic test results. So a physician may look at the signs and symptoms of an infection. Do they have some type of indwelling device? And what criteria, what is the minimum set of criteria or signs and symptoms that a resident must meet in order to have appropriate antibiotics prescribed? So we tend to, when we're using clinical definitions, want to focus on prospective criteria, so in the moment. And Shay has assisted us with these definitions. So the Society for Healthcare Epidemiology of America, along with minimum standards of initiating antibiotics in long-term care. There are another set of criteria. These are the Loeb minimum criteria. And another option for clinical providers is the Cooper urinary tract infection tool. So I'll go through these a little bit so that you have a better understanding of what each one of these is and how they can be applied in your setting. So the Loeb minimum criteria for antibiotics, this is work that was completed by a group of infectious disease specialists starting back in 2001, and it's been adapted since to include a variety of illnesses or infections that are commonly seen in long-term care facilities. So this is something that you may want to consider implementing. These are the minimum criteria for initiating antibiotics in long-term care. And it breaks it down by infection type. This one here is specific to a UTI with no indwelling catheter. So if you think about comparing our surveillance definition to our clinical criteria, they're quite different, but also similar in some ways. Never, ever are we going to use foul-smelling or cloudy urine as a valid indication for initiating antibiotics, and this is stressed through the Loeb minimum criteria for antibiotics. The new or worsening signs or symptoms, some of these are the same as our surveillance criteria, but they can also differ. So here is an example of the Loeb minimum criteria for antibiotics for an individual with respiratory illness. Again, you are focused on considering what antibiotics to start, if any, for a resident that may have some respiratory symptoms. So in the Loeb criteria, we have a fever of greater than 38.9 or 102 Fahrenheit. And we know that in our McGear definition, the temperature is quite low. It could be 37.2 or above. So again, those criteria are different. The other differences here, they include pulse, rigors, delirium, respiratory rate. These are things that are not included in the McGear criteria. So these minimum criteria need to be present in order for a physician or a physician extender to consider initiating antibiotics. This set of criteria are good to have where your physician is writing orders so that they can refer to this document, just like we have the antibiogram present for the physician to choose which is the most appropriate antibiotic based on your isolates and responses to antibiotics in the microbiology departments for your area. So again, this is a tool and it is best implemented right where the physicians are writing orders. The Cooper urinary tract infection tool was developed by a nurse. She basically took some data, analyzed it, and determined that maybe it would be best to have a set of criteria specific for urinary tract infections. This looks at whether there was a urinary catheter in place, whether the individual has mounted a temperature, are there other signs and symptoms present? And again, this is excluding that foul-smelling urine and cloudy urine. So really trying to determine whether the resident has a true infection or not. So this is another tool that you could use if you wish to. It could be, again, present at the location where your physician or physician extender is writing orders. It can also be used as a tool by nursing to make the physician aware of an individual that may have signs or symptoms of an infection and whether antibiotics should be prescribed will be based on the physician's determination. So what we want to do with our antibiotic stewardship programs is to minimize the use of antibiotics as much as possible. This can be accomplished by education for your physician and advanced practitioners on antibiotic stewardship. So maybe making it an annual competency that your physician and advanced practitioners participate in an antibiotic stewardship education program. Some of you are in facilities where you have a medical director and a small number of other physician providers. And so maybe one-on-one antibiotic stewardship education would be beneficial. You can use your pharmacy to assist you in identifying those practitioners that prescribe medications that are outside of the norm or do not have stop dates or de-escalation practices going on. The de-escalation practice is an antibiotic that has been prescribed maybe initially as an intravenous med, and then after narrowing the focus or identifying the contributing organism, you narrow that focus and can switch to an oral medication. The pharmacy could develop formulary restrictions and require pre-authorization in order to for providers to prescribe certain antibiotics. So maybe considering those what we call heavy hitters, not allowing the physician just to prescribe a heavy hitter for someone with, say, a common skin cellulitis or purulence at a wound. We encourage physicians and their advanced practitioners to use evidence-based practice guidelines. So what are the latest community-acquired or long-term care acquired practice guidelines for certain infectious processes? Again, that de-escalation of therapy. So after 24, 48 hours, having a timeout with the provider and determining whether the therapy can be discontinued, whether the therapy can be switched to a different administration, or maybe the length of time that the antibiotic is given can be changed. Optimizing antimicrobial dosing, such as using weight-based processes, that parental to oral conversion, and always, if you have the means, which I know is not always the case in residential treatment facilities, but computer-based order entry where the physician is required to justify the reason for the antibiotic, includes a stop date, and then also the right source or right administration. And then it is also very beneficial for physicians and extenders to have available the facility antibiogram, as this is going to guide a physician's ordering practices. So if you have a lot of organisms or isolates that have been evaluated by your micro department and the antibiogram shows resistance with some antibiotics, the physician will be able to determine which is the best antibiotic for treatment of a certain organism. So these are handy tools to have present when the physician is ordering antibiotics, and should be available in the location that he or she is writing orders. So Amanda, I'm going to turn it over to you, and I thank you.
Thanks, Christine. That concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. So we have one question here. How do I know if the number of infections in my facility is normal or an expected amount for the facility?
That's a great question, Amanda. So you want to look at your historic data, and you can do this by using the Patient Safety Reporting System analytics component of the program. It will display for you, after you put in specific parameters, what the volume or number of infections you've had in a particular category. The other way to do this is if you keep an internal line list. This would be a line list that you would keep by year with the number of infections with some identifiers, so you know the unit location, the date of the occurrence, and then also the organisms, if there's a common organism. You can use this to determine whether you have an increased number of events. You can also use this method to identify clusters or potential outbreak situations within your organization.
Great, thank you. We had another question just come in here. Where can I get an antibiogram?
Great question again. So an antibiogram is something that you work with your microbiology department. So if you are associated with a hospital, then you would contact the hospital micro department and ask them to assist you with a facility antibiogram. This is something where they will look at all of the isolates, the first isolate of an organism that you've sent in by resident, to determine the level of resistancy based on those susceptibility patterns that I shared with you previously. The other way to obtain an antibiogram is to work with your pharmacist. They may have access to an antimicrobial or antibiogram that they have collaborated with the microbiology department to create. But I would start with your micro department first. Sometimes you have commercial labs and they are required to provide those for you, and you want it for your resident population specifically, not the population of the entire region, but a narrow focus on your facility and maybe your very local community.
Okay, great. And I think we have time for one more question here. How do you explain to coworkers who believe the old thoughts that cloudy or foul-smelling urine indicates an infection?
So, cloudy and foul-smelling urine is not always indicative of a urinary tract infection. So, one of the ways to approach this is, has the resident consumed a normal amount of fluids in the last, 24 hours, or has there been a physical decline in the resident that they haven't been taking in oral products? So the foul-smelling urine and cloudy urine could simply be related to dehydration. So there are some schools of thought that, maybe you should hydrate the resident before you consider obtaining a specimen to send off for culturing. Probably the best way is just education that a urine that is cloudy and foul-smelling may not at all be related to an infection.
Great. I know that question comes up all the time, no matter how much you educate. So it's always good to give people a refresher. So this, I think that's all the time we have for questions today. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Mixell at shmixell@pa.gov. This concludes our webinar.